So to overview my talk today, I'll give you a little bit of basic consideration about the kidney to set the scene, and I'll then talk about renal disease in people who live with HIV. Then focus down on ART and the kidney and give you what I think is the key evidence base for the decisions we make about ART choices. I'm going to talk a little bit in focus about tenofovir, because TDF tenofovir has been our biggest concern, and a key question emerging is whether TAF is a real step forward in terms of delivering tenofovir for HIV. And I'll try and summarize the whole of that in one slide at the very end. So first of all, basic renal stratification. This now, we have to be clear, has two dimensions to it. When we talk about renal monitoring and renal status, we have a dimension of function, which is GFR, and you can see that listed on the left, going from normal above 90 to less than 15, which would be with kidney failure near to dialysis. And the other dimension we have is proteinuria, plotted here as albumin-creatinine ratio across the top, going from less than 3 to above 30, A1 to A3. So when we define a patient's renal status now, we need a G status and an A status. And that's becoming increasingly important as we recognize that the higher A status creates a higher risk of progression to worse renal function, and is a really important part of our assessment of patients. So what are the concerns in HIV care? This summarizes, I think, the key things that should be in your mind when you're thinking of kidney care in HIV setting. First of all, what is the present function in terms of those G stages? And I would regard any patient with eGFR below 75 as a patient I'd need to flag up as someone I need to be vigilant about with respect to renal status and future. And secondly, how much proteinuria do they have? And I'd flag up patients who have A2 or A3 proteinuria on that chart as those I should be concerned to be vigilant with. What is future risk? Future risk is determined by a number of really important factors which we can very easily detect at baseline. Older patients, type 2 diabetes, hypertension, cardiovascular risk and event patients, people who need nephrotoxic medications in other areas of their medical care, and the renal safety of the ART contributes to our management of future risk of renal disease. Having significant renal disease in the HIV setting really matters. This is a study we did at King's some years ago, looking at patient survival stratifying by the presence of G3 to G5, that's stage 3, 4, 5, significant chronic renal failure. And you can see that the 5-year survival is impaired down to 75% by that diagnosis. And that's just the headline. Those patients remaining alive suffer significant morbidity, symptoms, and impact on their lives. For example, many of them will go on to need dialysis treatment. So we want to avoid patients entering this zone of significant renal impairment, eGFR below 60. We also need to be aware that in the background population, as we'll hear later today, there's an increasing risk in the HIV population as it ages of multiple comorbidities. And these are contributing directly and indirectly to our burden of renal disease in the HIV setting. That is not a stationary target, but it seems to be a moving target. And you just focus here on the left-hand side. This is a study from the Aquitaine region of Western France, looking at the prevalence of different comorbidities, comparing 2004 with 2014. And you can see across the board, but I focus you on the left for present purposes, that prevalent chronic kidney disease has become significantly more important and more prevalent in that 10-year period. Part of this is better acquisition of information, but underlying it also is a true increase in the incidence of these diseases. And in terms of CKD, part of that is aging, other comorbidities, but we must be aware that part of it also can be the way that we use ART. How big is the problem of kidney disease in the HIV setting? These are the EuroCEDA data from some years back, and you can see that the new development of CKD in the HIV setting is occurring in between 4 and 5% of patients over a 4-year period. This includes everything. My best estimate of how much ART contributes to that is probably 30 to 40% of it is ART-related CKD. And as I just said, this study is from some years back. Undoubtedly, this is an increasing problem because of the nature of the demographics of the patients that we are caring for. So a significant problem, and for those patients who develop CKD, I think I've shown you there is a significant morbidity and indeed mortality attached to it. What about the key factors and how much role does ART play in the development of kidney disease and its progression in patients living with HIV? These are the Eurocedar cohort analysed statistically, and you can see the factors underlying the risk of developing CKD. These are multiple, function at baseline, low function, older age patients, patients with comorbidity, hypertension, diabetes, and then you see at the bottom the cumulative exposure to some key ART, and I'd focus here on tenofovir, TDF, atazanavir, and boosted lopinavir. These are consistent findings, not just found in the Eurocedar cohort. And the point to make straight away is that these are not independent lines of risk. If you have the risk of, for example, diabetes and being an older patient, the absolute risk of having a toxic ART therapy is greater. So we must view these risks together when we look at individual patients. The atazanavir story was a surprise from that data set, but there is some independent evidence that atazanavir, particularly if co-administered with TDF tenofovir, does carry a risk of a negative trend of kidney function. And this is a study over a 1-2 year period demonstrating small but definite differences in renal outcome with a negative trend of function in those patients who were prescribed that particular combination of boosted atazanavir with a TDF-FTC combination. Protease inhibitors also have renal risk signals, and the overall data is still not entirely compelling, and I show you some example here of the hazard ratio associated with being on some different boosted protease inhibitor regimes. And although not all those hazard ratios are significantly different from one, you see the confidence intervals are quite wide. I think we have to regard all boosted PI regimes as a potential risk, particularly in combination with TDF tenofovir, and they should be used when they are with a great vigilance about monitoring of renal function. So here is a bit of a deeper dive into that data that showed how a cumulative exposure to different ARTs carried increased risk of new development of chronic kidney disease. But I want to focus you briefly not at the 3 drugs I've mentioned already, but the right-hand side here, baccavir. This difference here that you see between not exposed and a short time on baccavir is an example of reverse causality. The cumulative exposure to baccavir is not creating increased risk of renal disease. What we're seeing is the tendency to choose baccavir as therapy in those who have higher risk of CKD. So we need to be very clear about that. There is no robust or even suspected link between baccavir and CKD. And baccavir appears to be a drug the kidneys do not see when it's used in therapy. And I think that's been a consistent finding. We can use the DAD study and the data, the nature I've just shown you, to create very simple risk factor stratification for HIV patients. Here's an example of such a risk factor stratification. You can give people scores for various things, being older, having poorer baseline kidney function, having high blood pressure or diabetes, and you can end up with a low, medium and high CKD risk. This is a valuable thing to do. You can do it like this, you can do it in other ways, but I think it does matter to get a baseline assessment of renal risk in the patients we're going to treat or that we are treating. One reason it matters is shown here. If you look at the number needed to harm we call harm here developing new CKD stage 3 or worse, you can demonstrate that those patients who have high risk at the initiation of therapy and are then started on therapies which we've identified in the data I've shown you as being renal risk linked, then the number needed to harm over a period of therapy of 4 to 5 years comes down to the range of 10 to 30. Probably not acceptable to be given treatment that has that chance of causing harm in our patients. And that's why the baseline assessment of risk should be used to inform and educate us about the risks of individual therapies in these patients. So I mentioned renal risk calculators. The data from DAD is available as a calculator through Copenhagen University. Very simple to use, binary input, diabetes, yes or no. It gives you a risk of CKD within 5 years. It includes the ability to modify the risk by ART. If you're going to use TDF tenofovir, it'll tell you what the risk change takes place. If you use atazanavir, it'll do the same for you. In my view, having done some analysis of this risk calculator, if your morbidity is severe, it tends to underestimate its importance. So if you've got uncontrolled 3-drug hypertension and uncontrolled type 2 diabetes, then just clicking yes or no on this risk calculator is not giving you enough of a risk for that individual patient. Counter to that, the UCFF database will also give you a risk calculation. It's more complicated to use. You need to know the fasting blood sugar, the triglyceride levels. It's a more sophisticated input, and it probably gives you a more accurate result, but it's all based on data from men. So there's a problem if you want to use it for assessing risk in women. But it will give you risk of CKD within 5 years, and you can look at TDF modification of that risk. I'd recommend that you look at these calculators and be familiar with them. Those patients who do develop a TDF-induced problem, the most severe one is to get a tubulopathy, a Fanconi syndrome, probably occurring in about 1% of patients who start TDF, can cause, as seen here, very severe renal disease, lead to phosphate wasting and significant bone disease. And we've developed very good programs over the years to detect these cases early and prevent them becoming what is shown here, which is actually a relatively neglected case of Fanconi syndrome, where TDF continued despite the first features. But TDF does cause other significant problems, even in patients who don't get a full-blown Fanconi syndrome. It does increase your risk of proteinuria, of developing CKD, and of a rapid decline in renal function. And so handling TDF has become one of the great skills of HIV clinics, and your teams have become very good at renal medicine, in fact, because of the need to handle TDF carefully and safely. A key question about TDF is how do you predict patients who really should be taken off the drug? And a study we published early this year tried to look at the antecedent renal function in patients on TDF who then developed a clear tubulopathy. And we used a case control methodology showing that if you looked in the past and found there was definitely what we might call creatinine creep or GFR decline of 3 or 5 or more mil per minute per year, that was a pattern very common in subsequent cases and rare in those who did not become cases. So we would advise on this basis to consider a relatively definite decline of GFR as a reason to review TDF prescribing, because the patient's developing a risk of becoming a Fanconi syndrome case. I should say that when I say eGFR decline, I don't mean one number a year ago and one number today, because the errors in these numbers are great. You need a robust series of measurements that you believe represent a decline in renal function before you should take clinical action on that basis. A key question about TDF toxicity is, to what extent is it reversible? The more reversible it is, the more relaxed we can feel about the agent. This study demonstrates on the right-hand side that if you look over time, 75% of patients show full recovery when TDF is stopped for a renal problem. And in those cases, of course, that's a good outcome. But 25% of patients seem to show some irreversible component to the problem. And a key question is, what is the risk of being in that 25%? What modulates that risk? And the evidence there is that the result is not surprising, that you are more likely to be in the irreversible group, that is, you have suffered irreversible damage, the longer you've been on TDF, and the lower renal function has got before you stop it. For example, if you don't stop TDF until GFR is below 75, you're 2.5 times more likely to have an irreversible component to the damage that's arisen. And I think, again, this should inform practice when you're looking at trends of GFR and absolute numbers in patients on therapy. So let me turn now just for a few slides to this other way of delivering tenofovir, which is TAF. And this slide actually illustrates really the pharmacokinetic issue with TDF. That is that it's unstable in plasma, therefore significant free tenofovir is generated, and it's the free tenofovir, TFV, which is taken up by tubule cells and creates a localized kidney toxicity. And the theoretical advantage of TAF has been that it's stable in plasma, low levels of free tenofovir are generated, and TAF is taken up directly into lymphocytes where it can release TFV. And the kidney should experience little toxicity in theory because there's low levels of free circulating tenofovir. So the pharmacokinetic theory is great. The question is how does this play out when this drug is used in practice? And I'll just go through that briefly. So if you look at patients successfully treated with either TDF or TAF-based regimes, it is clear that the free tenofovir levels are an order of magnitude different. These patients are all successfully having viral control. On the left with TDF regimes, area under the curve free TFV is about 4,000. On the right with TAF, it's an order of magnitude lower. So the pharmacokinetics appears to do what the drug is supposed to, that is low free TFV. The main study that allowed TAF to be licensed for patients with significant renal impairment down to 30 was this, where patients with baseline GFRs between 30 and 70 were switched to TAF, and this data shows very clearly, without going into detail, that renal function remains stable on the TAF-based regime over a period of 2, there's now data for 3 years, showing that to be the case. So the use of TAF in patients with pre-existing renal disease appears on the basis of at least 3-year data to be kidney safe thing to do. The biomarker data is actually fascinating. It's a very busy slide, so I'm just going to concentrate on one thing only here, which is this column called RBP. If you're on TDF, you tend to have raised RBP in the urine. That represents tubule stress. There is an inability to reabsorb low molecular weight proteins. And if you switch TDF to TAF, you can see that falls dramatically, 1525 down to 173. So the TAF switch from TDF removes the TDF stress if tubule reabsorption of low molecular weight protein. And essentially this slide, although it might look to be about TDF switching to TAF, it's nothing to do with TAF, it's all about what happens when you stop TDF. This is demonstrating that TDF has an effect on kidney tubules. It's causing a stressful inability to reabsorb protein, and that's removed when you stop TDF. And the TAF appears to be neither here nor there. It doesn't get noticed by the kidney. So if you were never on TDF, the changes are insignificant when you start TAF. Those are all really preclinical and subclinical issues. What about the patients? If you look at the licensing studies that compare the TAF and TDF-based regimes, then the discontinuation rates for renal reasons are clearly different. And you can see what you would expect on TDF regime. About 1 to 2% of patients have to stop the drug for renal reasons, even in this low-risk group recruited for an IU study, and the discontinuations on the TAF regime are 0. So the bottom line is that the TAF regimes appear to be benign as far as the kidney is concerned, and the evidence on that is short-term, medium-term, and now growing. So TAF has, I think, joined a group of drugs that we can use that appears not to have a renal signal on current evidence. So to finish and put all that together on a single slide, And to do so, I've had to take a simplified approach. I'd just like to finish with the following comments. So, as you are aware, people with HIV need baseline and ongoing assessment of renal function, and we need to be aware that's a two-dimensional assessment with eGFR and proteinuria. You can use ACR, you can use PCR, but you need to use something to get that second dimension. Secondly, signals of renal toxicity have been associated with certain ART, and I've shown you some of the evidence, but notably TDF-tenofovir, atazanavir, boosted lopinavir, and all boosted PI regimes in combination with TDF in particular have to be considered to be used with vigilance. ART not associated with renal risk include a baccavir, TAF, the NNRTI, and the integrase inhibitors. And renal risk assessment should be used to guide choice of ART, and I'd recommend, I haven't talked about them in detail, both your national and international guidelines. So in the UK, we'd look at the BEVA guidelines and the EACS guidelines. And generally, I see the guidelines process in HIV care as being very effective and rapidly taking into account new evidence. So your guidelines are actually good for leading and providing quality of practice, and I would recommend them to you. And then a final point, which I haven't really talked about in detail for reasons of time, but if you have established CKD with HIV, you clearly need continued therapy. It will be of great benefit to see an increasing use of unboosted regimes, because the key issue we have in our care of people with significant CKD are drug-drug interactions, and the booster is often the key problem in the middle of that. So we already have some unboosted regimes. We are going to see more of them, and my prediction would be that in this HIV interface with kidney disease, the unboosted regimes will become a really important part of the way that we care for patients. So, thank you. I will stop at that point. Thank you very much.